Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk about two articles written by real leaders in the field of providing services to individuals who have criminal justice contact and who have serious mental illness. Elizabeth Ford from New York City and Mark Munetz from Ohio.
Should be great. So today we're doing something a little bit different. We're actually going to do a joint interview of two authors of papers in psychiatric services that Lisa and I thought were related and kind of spoke to each other in an interesting way. I think it'll be a really interesting conversation. So we're incredibly lucky to have Mark Munetz, who wrote a personal account on Black Robe, White Coat, Mental Health Providers Must Reclaim the Role of Caring Clinician, and then Elizabeth Ford, who wrote or co-authored a paper on clinical outcomes of specialized treatment units for patients with serious mental illness in the New York City jail system. And Mark is coming to us from the Northeast Ohio Medical University, and Elizabeth is a associate professor at NYU Department of Psychiatry, former chief of psychiatry for Correctional Health Services in New York City. So Mark and Elizabeth, thank you so much for joining us.
Thank you.
Yeah, happy to be here.
So, one way that we usually start out these interviews, and I think it might provide some context for our listeners, is to get a little bit of a sense of how each of you became interested in either the field that you're in general or the particular topic of the paper, to narrow it down a little bit maybe. So maybe, Mark, we can start with you about what led you to a particular topic.
Sure, and it's a long story that I'll try to make short, but I've spent much of the last 20 years as a community psychiatrist in Ohio, trying to work at the state level with each local community to reduce the overrepresentation of people with serious mental illness in the justice system. And I was approaching retirement around the time that I wrote the essay, having sat in on a consultation at the county where I'd spent most of my career trying to make the mental health services as good as they could possibly be, and was kind of distressed to see and hear kind of the state of the field right now, and took the opportunity to reflect on that.
And Elizabeth, how about you? Where did you come to this from?
So similarly, I have a pretty long story that I'll try to make short. I in residency, was introduced to the population of patients who were incarcerated when I worked at Bellevue Hospital, and for the past 20 years have devoted my clinical work to taking care of them and to try to advocate for the care of that population. When I left Bellevue and went to the jail, to Correctional Health Services about 6 years ago, the mental health care that was happening at that time was fragmented and stigmatized, and it was very hard to interest any psychiatrists or, frankly, any mental health professionals in taking care of the patients who were there. And so my job at Correctional Health was really to try to improve the mental health care for the thousands of people who were jailed in New York City who had mental illness. And this paper really is a testament to years and years of work trying to have very team-based and patient-centered care in a jail, which is relatively uncommon in this country.
Well, Elizabeth, why don't we start with your paper? Can you just give us the kind of broad outline about what was going on in the jails? Talk us through some of the PACE units that you describe and what your study was looking about and found.
Yeah, sure. So just a little bit of an introduction. The city very generously provided enough funding in 2014 for the jails to actually develop and design strong and thoughtful mental health units in the jails. And that was the first time that anything like that had happened in the jail system. So we were given the finances and the support to do that. The the healthcare providers and the Department of Correction, which is the custody agency in New York City, they're both independent agencies of each other. We worked together to develop what we considered to be the optimal care that we could provide in the jail. And that was based on what I and others had learned taking care of patients in the hospitals. That was based on all the standards of care we could find in the community and what we could legitimately do in the jail. The biggest challenges we faced were patients with serious mental illness who would go to the hospital, become stable in the hospital, and then return to the jail, and very quickly, sometimes within the matter of days, decompensate, have to go back to the hospital, and they would get in this cycle that oftentimes extended their incarceration in the jail. So we built these units as a way to try to reduce that sort of frequent flyer phenomenon and to provide what we hope was a stabilizing environment for the patients in the jail system so that they could not only avoid bad outcomes, but possibly even become stable and have their mental health taken care of. So these units developed over the course of many years. In fact, there's funding to build 6 more of them even now. So this is ongoing. And the paper, the study was designed to try to figure out if what we were doing for these patients was actually helpful. And it is uncommon in the correctional literature to find studies that actually look at the impact of a large program on a patient population. The vast majority of literature you'll find will be identifying the challenges and the problems, but very little of what possible solutions may exist. So we really wanted to see if what we were doing was working. There was a lot of money and time invested, and if it wasn't going to be helping patients, then it wasn't going to be worth it. So we looked at 2 groups. It was a matched control sample. The first group were patients, about 300 patients who the inclusion criteria, which we could talk about in more detail if you want, who had gone through the PACE program, and they were matched with 300 patients who, because of bed availability, weren't able to be in the PACE unit. And these populations were very closely matched, and we looked primarily at whether we had an impact on the rates of self-injury, the rates of violence due to fights between patients, and medication adherence. These were considered very important healthcare outcomes for those patients. And we found that violence due to fights, so these are peers fighting with each other, decreased significantly with both at 1 month and 2 months on the PACE units. And then finally, we found that medication adherence increased about 40% on the PACE units as compared to regular mental health units, and that was statistically significant. I think just an important note is that the jail does not do treatment over objection. So none of the medication adherence was through coercion or force. This was we think the result of a very team-based, patient-centered approach.
Yeah, and you just for the listeners, obviously we want you to read the article, and Elizabeth, the authors go into much more detail in the actual paper about all of the procedures and the matching and the data and the outcomes, and even the issues around, again, treatment over objection. So it's really Elizabeth gave the highlights, but there's a lot more really important detail in the paper.
And so, Elizabeth, if you had to do a one sentence take home from the paper.
That taking care of patients from a rehabilitative health perspective rather than a punitive perspective has really significant impacts on their health and well-being.
So let's pause there for a second. And Mark, can you walk us through what your paper was? You alluded to it a little bit about the genesis of it, but can you tell us walk us through your experience in the mental health courts, and then how you kind of explore that in the paper, in the column a little bit?
Sure. So in reality, because we have so many people with serious mental illness coming in contact with the criminal justice system at the level of law enforcement, sheriff deputies, as well as judges and everyone else in the criminal justice continuum, there are individuals who've stepped up, law enforcement with crisis intervention team programs, and judges primarily with specialty docket mental health courts to try to address what they see as a failing mental health system. And I've had the privilege of being in contact with a number of such people who are remarkable people, and they're incredibly committed and creative. And some of them are very skilled in their interpersonal relationships. And so in the essay, I was using mental health courts as the example, and a true story of a contact with a judge who was describing a relatively new program, and she was really excited about the outcome she was seeing, and said that individuals in her court told her repeatedly that she was the first person in authority who really showed that he or she cared about them as individuals rather than just a sort of a cog in the wheel of the mental health system. And when I heard that, on the one hand, I was very grateful and had a lot of admiration for the judge. But on the other hand, especially sitting in an office in the county where I had spent most of my career trying to improve mental health services, it was very discouraging to hear that there had not been a mental health professional, a psychiatrist or other mental health professional person in authority who these individuals in these mental health courts who are very well known to the mental health system had felt really had cared about them. And that's what really motivated the essay. And that as creative as the judges are, why can't our mental health system be similarly devoted and creative to meeting the needs of a very high need population?
So on one hand, it sounds like these are very different, settings. Obviously, both thinking about how to serve a forensic population better and more humanely. But you have mental health courts on one hand, and outpatient treatment, and then treatment in actual forensic settings like jails with Elizabeth's paper. But I think there's also a ton of overlap here before, but I'm interested in hearing how you each saw each other's articles and where you saw these areas of overlap. So maybe Elizabeth, we can start with you about what is your ear with all of your years and experience and what you lay out in your article. How did you hear Mark or read Mark's paper?
Well, I completely agree with the ideas that he wrote. I do think it's important for the audience to know that we're talking about the same patients, just at different stages of their trajectory in the criminal justice system or in community psychiatry. I have been taking care of them either in the hospital or in the jail. The community and the mental health courts and the ACT teams and all of the other providers take care of the same patients just when they're out of the institutions. I have felt pretty strongly and try to impart this to people when I talk to them that these are these are patients who are deserving of as much care as we give to anybody. And I think that in my experience of the mental health community, I'm most familiar with the psychiatry one, is that we as a profession tend to shy away from this population. And maybe it's because most psychiatrists are not familiar and haven't experienced the things that their patients have gone through, and so maybe fearful of that, or may not have as much curiosity as they could. And that kind of approach to patient care, I think, really disincentivizes the patients to engage and does a disservice to the therapeutic relationship. The comment that Mark made about the judge or the patient saying that this was the first authority who had shown an interest in them is devastating, but also resonates with me. I have throughout my career frequently had patients come up to me after I shake their hand and just say, "Hi, Mr. Smith," and they'll say, "Oh, you're the first doctor who's ever shaken my hand before," which to me is awful. I think it's the same sort of comment that the judge was hearing. So that's my first impression. I have a lot of others, but Mark, you may have something that you want to share.
Sure. Well, I absolutely agree. We're talking about the same patients. And one of the points for community mental health, I think, that's really important is to recognize that the people that we're seeing in community mental health agencies are the same patients. A very significant proportion of people seen in public mental health settings have had justice involvement. And thinking about forensic patients being somehow qualitatively different than other patients, I think is wrongheaded. I think a majority of the patients we see are just the patients we see. They're all the same. And some of them, a significant portion of them have justice involvement at some point along the way. Our goal is to minimize that. What resonated for me in your study was how you and New York City, I really think, should be commended for putting mental health in charge of the mental health units in jails. I think that's quite unusual. Instead of trying to accommodate to corrections, you brought corrections in and trained them, as you described in your paper, to fit into a culture that's a therapeutic culture rather than a punitive or correctional culture. And that's pretty remarkable. And I've not seen that in very many places.
Well, it's, I agree that the city, it was pretty remarkable. New York City, because the healthcare agency, so correctional health, does not work and is not contracted by the Department of Correction. I do think that it made it in some ways a little more challenging, but in other ways easier to come independently into the setting and say, hey, I'm a doctor, we're going to take care of the patients. And the security agency really, they couldn't say no to that. I would also add, though, there were some very important partners in the Department of Correction, some key captains and deputy wardens who had seen the evolution of the jail and the care of patients with mental illness and really wanted things to change. So there were some key, I would say like a handful of really influential corrections officials who helped marshal this project in. And I think if you don't have somebody or a few people who really believe in the mission, it's very hard to make changes like this in a jail or a prison.
So I'm curious, if I had not read anything else in my life on this topic, I might come away thinking that the jails and prisons and sort of the correctional whole side of things was super fantastic. We have the Black Robe folks who are, and Mark, in your essay, that you mention examples of really, I think, probably innovative and extraordinary programs. And then obviously, in Elizabeth, in your paper, you provide data and conduct research on your innovative program. Is that a fair appraisal? If I were to just read these two papers, would that be a good way for me to understand what's out there?
Not exactly, I don't think.
Me either.
So to build on a comment Elizabeth made a moment ago, finding really committed partners in the justice system, judges, police officers, probation, parole, throughout the system is really critical to our mission, which is largely to try to keep people out of the justice system and keep them in the treatment system. So I think much more energy needs to be put into keeping people with serious mental illness out of jail, out of the justice system at all points as we possibly can. But at the same time, inevitably, the nature of serious mental illness is such that people are going to still get into the system. And when that happens, then we want to have the best services that we can possibly have. And I think that's what Elizabeth's program was working towards doing in the jail.
Yeah, I agree. I never want to be in a system where you get better health care in a jail than in the community. That to me is backwards. However, it also strikes me if the patients are in jail and at the time that where decarceration efforts are starting, which is great, but at the time these started, the jails were full patients who needed care. And so I don't think it's okay to ignore a huge population of patients just because they happen to be in a place where you don't think the best care can be delivered. So these units are really, it's harm reduction. It's doing the best we can in a particular environment. I wish that we didn't have to give any care in the jail, because that would mean patients were coming in very quickly, or they weren't coming in at all, and they would be getting as much as they needed in the community. I don't think that we're there yet. I don't think New York City certainly is there yet. It is, in fact, why I've made the decision to leave the jail and move into the community to try to have some kind of an impact with patients who have criminal justice involvement so that they don't go back into the system or don't go in there to begin with. But Lisa, to your question, these units were built because we couldn't tolerate bad care in the jail, but certainly not as a replacement for community care.
I think part of also what I was asking about is how unusual are the example, is the example of your program, Elizabeth, and how unusual, Mark, is the example that you provide in your essay about the judge who is so clearly committed to people with serious mental illness. Is it unusual, or is it something that you see all the time?
I think there's an increasing prevalence of committed judges across the country. Actually, the American Psychiatric Association has partnered on something called the Psychiatrist Judges Leadership Initiative, pairing up judge leaders with psychiatrists to do training of judges around the country at a statewide level. And I've had the privilege of doing a couple of those, and we get a very engaged audience of judges because they're seeing these individuals, our patients, all the time, and they're frustrated and realize what they've done traditionally isn't really effective, and so they want to learn how to do things differently. So it's not unusual, and I think it's wonderful. And I do want to make a similar comment about police officers around the country who've embraced the crisis intervention team CIT model. They're important partners, and we're fortunate to have them, and need to help them do the best job they can do, but not give them our job to do.
Yeah, and I would, from the jail perspective, it's definitely not uncommon to have both healthcare and custodial staff very invested in improving the care that's delivered in the jail. I think the challenges are largely resource driven. So there's not enough money. There may not be enough expertise. The jails may be located in places that are difficult to get to. So it is not for lack of interest, but I think at this point it's lack of funding, basically.
It seems like a good opportunity for me to point out that the mental health system not doing as well as it might do, that the judges and police officers complain about, is also not the result of a lack of caring or commitment. I also think it's about a lack of funding. That we tend to do what we're paid to do, and the reimbursement system. It's another point I made in the paper, and certainly not the only explanation, but it's a big part of the story as to why our mental health system isn't doing a better job.
Do you think if the funding improved, people, I guess either both on a individual level and a systematic level, would be more empathic towards this population? I guess another way to put it is, what's driving what? Do we need to work on kind of increasing the empathy of people and allowing them to see people as individuals, and that will drive further funding, or does it kind of...
Or even to see the effectiveness of these programs, right? That would be another strategy to drive funding.
So I think that the question of developing empathy for this population is a difficult one. I absolutely think it's possible, but doesn't come without, but I don't think can be attained without exposure to the population in a real and significant way, and in a in a way that develops relationships, like Mark was describing in his article. So I think funding does not just mean staffing and overtime and and like environmental changes. I think it also means funding for trainees to come to the various settings and learn and engage with the patients. It means allowing a workday to include education and groups and interactions with other professionals and peers. It allows for not having to see 10 patients back to back with no time for charting. It allows a much more, I think, in my opinion, a professional environment that allows people to really access their inherent empathy. When you don't have a system like that, everybody is just struggling to get through their day and get out. And that does not in any way foster empathic feelings to the patients, I think, or to each other.
And maybe this is a related question, and maybe it isn't. I'm wondering if you could each just talk a little bit about what it's like to write more personal reflection. I know, Elizabeth, this isn't, the paper you have here isn't a personal reflection, but I know that your book contains a lot of it. It's a memoir. And I wonder if that's kind of what both of you are getting at in that sort of work around creating some sort of more empathic feeling for the population, or if you see that sort of personal disclosure, or I guess how you see that personal disclosure kind of interacting with the field and moving things forward.
Well, from my perspective, I have not had any success engaging people around this patient population without sharing with them my own experiences. And it's taken me some time to be comfortable doing that, but it has helped me enormously. I find it very therapeutic. I find that the feelings that I have had in these settings, which I have thought are only mine or only confined to this particular environment, are not at all. And that many people can relate to the same things that I'm talking about. And that many people find that they feel very compelled to take care of these patients. They just haven't figured out how to get through the practical hurdles to do that. And so I find it very useful. And the paper, the psychiatric service paper, you're right, is not a personal reflection, although if you read the article closely, you may notice points where I did try to actually inject some narrative and a little bit of a story, because sometimes I do find that articles that are too dry or too academic sometimes will lose the reader's attention, and they'll miss the passion in the work. So there were little moments where we tried to do that in the paper.
We saw them. And Mark, what was the personal account sort of process like for you?
Well, I think there was a catharsis involved in being able to express in the first person some of my distress and sadness, in fact, that we put what should be our job and created a burden for our colleagues in the justice system who've taken it on. I mean, as I said, I have affection and respect for the judges and officers I've gotten to know over the years. But it's nobody's fault within mental health. I don't want to, I'm not ranting against my colleagues in the mental health system. I think we have an impossible job to do and have been doing the best we can. But it was nice to be able to express some of that, particularly as I was getting near the end of my time officially working in the system.
Yeah, I underlined the sentence that you wrote. On the other hand, I was distressed beyond words. And that really hit me when I read that sentence.
And I think that's an accurate depiction of how I was sitting in a room with people. There were consultants there, which is the reason we were all there. But I was in a room with colleagues I've worked with for a very long time, and hearing the amazing things the judges was doing, and in the context of hearing about how the mental health system was failing these patients from the point of view of a fairly objective professionals and on the other side in the criminal justice system. It was very distressing.
So I have one last question for both of you. I see you two as giants in the field of improving and focusing our efforts and making lives better for people with mental illnesses who touch the criminal justice system. I see you, Elizabeth, as kind of more like mid-career, and Mark, you've identified yourself as someone who's retired. What advice do each of you have for our younger listeners, both to inspire them to get into this work, specifically with this population, and what should they do to make a big difference? What's their what should be their North Star?
Well, that's a good question. I think my advice, honestly, is to find what they love, which I know is everyone says that, but it is absolutely true. And to not be afraid to use their voice as a doctor, both to take care of their patients, but also to advocate for things. I have found that particularly in this setting, that's not a healthcare setting. So criminal justice was not designed to be a healthcare setting in any way. But your voice as a doctor is extraordinarily compelling in those settings. And so I think to remember why you're interested in it, to stay grounded with the patients as much as you can, and to use your voice strongly. I do think it requires additionally some staying power. I mean, these are very difficult systems to work in, very difficult, and there will be pushback really at every turn.
So just to follow up on that question, let's just say you're not a physician and you're a listener, is it fair to say that other speaking out as in other professional capacities would be heard and important?
Yeah, thank you. That's an excellent point. Yes, I think anytime you come from the perspective of the patient first, and of course that's not just exclusive to doctors, that's to any individual who's taking care of a patient or a client. Anytime you come from that perspective, it raises the power of your voice, and it puts you in a position where you can be heard as objective and not lobbying for a particular interest other than doing what's best for a human being. It's very hard to argue against that. Mark,
you get the last word.
Well, I agree with what Elizabeth just said, and I'm not sure I could say it much better. I mean, so in the mental health professionals, so one thing that I've heard judges joke about is that they've come to see that they respect psychiatrists more than our fellow mental health community does oftentimes. So don't underestimate how we as physicians are viewed, and we do have to get past the turf issues in terms of physicians with other mental health professionals. We need to have a united front and work together to advocate for what's best for our patients. I wouldn't be afraid to speak up, and I'm a inherently shy person, but I've had to learn how to speak up not only within the profession, but then and within mental health, but across systems. And our young colleagues should not be afraid to get to know the chief of police or the judge, whether it's in the civil commitment court or the criminal courts. And I agree, you have to be prepared for a long, ongoing journey. There's no quick fix to the very complex problems that we're trying to solve.
Well, we want to thank both of you for both putting in that work and that commitment, and also sharing this with the readers of the journal, but also our listeners here. It's reading both of these articles and some of your other work has been very inspiring to me in my career, and so I want to thank you for that as well. So we'll look forward to having you back on for maybe our second group podcast episode when you both publish your next articles in the journal.
Thanks so much.
Thank you very much.
Thank you very much.
Wow, that was really intense to interview those guys. That's it for today. We invite you to visit our website, ps.psychiatryonline.org to read the articles we discussed in this episode, as well as other great research and stories. Please check our Editor's Choice topic collections available now. The most recent one is on health disparities among people with serious mental illness. We welcome your feedback about the podcast. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.